Hello and welcome to this presentation on Crohn's. There are two parts to this presentation, as inflammatory bowel disease consists of Crohn's and ulcerative colitis. We are going to be talking about Crohn's. Let's start off with a few questions. Which of these is a type of inflammatory bowel disease? The answer is Crohn's. Which of these is not a layer of the small intestine? The answer is lamina propria. And where are fat-soluble vitamins and vitamin B12 mostly absorbed? In the ileum. It is important to know what vitamins and what minerals are absorbed at which location of the gut, as it becomes significant later on. We'll be talking about Crohn's, the pathophysiology and histology, symptoms and history, the clinical examination, investigations and differential diagnosis, and management and surgery, and finishing off with a few questions. What is Crohn's? A disorder of unknown etiology characterized by transmural inflammation of the GI tract. It is a type of IBD. The bimodal peak age of presentation, 15 to 30 years, then 60 to 80. It follows a remitting and relapsing course. It has a family link, and smoking increases the risk of developing Crohn's. However, for ulcerative, it's protective. However, do not advise patients to smoke, as it causes other harmful effects. It's a transmural inflammation leading to fibrosis causing intestinal obstruction. It can also result in sinus tracts burrowing through and penetrating the serosa. These are called fistulas and perforations. It leads to a cobblestone appearance, which produces deep ulcers and fissures. There are skip lesions and non-caseating granulomatous. The histological difference between ulcerative colitis and Crohn's are the location. Ulcerative colitis is the large bowel, and Crohn's is the entire GI tract. Inflammation of the UC is mucosa only, and Crohn's is transmural. The microscopic changes, UC is non-granulomatous and Crohn's is granulomatous. The macroscopic changes in UC, there is continuous inflammation, and for Crohn's is discontinuous, i.e. skip lesions, cobblestone appearance, and can have fistula formations. The symptoms and history are there chronic diarrhea, weight loss, right lower quadrant abdominal pain, perianal lesions, blood and stools, fever and fatigue. For your clinical examination, you want to ask about abdominal pain. Do they have diarrhea? Do they have oral aphthous ulcers? Systemic symptoms such as malaise, anorexia, or low-grade fever, and perianal disease. Some of the extraintestinal manifestations that could present in the MSK, enteropathic arthritis or metabolic bone disease, skin, erythema nodosum, pyoderma gangrenosum. Do they have episcleritis, iritis, or anterior uveitis? Hepatobiliary, gallstones, and renal stones. Something that you would have noticed, Crohn's is an inflammatory bowel disease, so it's related to inflammation. So if the patient is likely to have an inflamed bowel, then they are likely to have other sources of inflammation, as those listed in front of you. For the investigation, do they have anemia? And do you want to do some iron studies? As we had mentioned before, that B12 is absorbed in the terminal ileum, and terminal ileum is most commonly affected in Crohn's. You want to check for inflammation markers, LFTs including albumin, and fecal calprotein as it was raised in IBD, but not in IBS. You'd also want to do a stool sample to check for C. difficile. Some of the imaging that you'd want to do is a colonoscopy with tissue biopsy. You get mucosal inflammation, discrete deep ulcers, creating the cobblestone appearance and skip lesions. You'd also want to do a barium swallow, an abdominal chest x-ray, and a pelvic MRI. Differential diagnosis: ulcerative colitis, infectious colitis, pseudomembranous colitis, acute appendicitis, and colorectal cancer. For your management, for the acute setting, fluid resuscitation, nutritional supports, prophylactic heparin, and medical management, corticosteroid therapy and immunosuppressive agents. Maintaining remission, azathioprine, smoking cessation, colonoscopy surveillance, and enteral nutritional support. For the surgical side, indication of failure medical management can lead to severe complications. So the most common procedure is ileocecal resection, removal of terminal ileum cecum with primary anastomosis between ileum and ascending colon. This is why most common complication is gallstone disease, as there is reduced absorption of bile salts at the inflamed resected terminal ileum. Let's end off with a few questions. Which of the following investigations should not be performed during an acute flare-up of Crohn's? The answer is colonoscopy, as there is a risk of perforation. Which one of these will not see in a Crohn's patient? Abscess. These form in ulcerative colitis. And what is the most common surgical procedure for Crohn's? Ileocecal resection. A colectomy is the removal of most of all the colon and needed in severe Crohn's or UC only. Thank you very much for listening to this presentation.